Okay, so for those of you who don't know me, which I imagine is probably most of you, my name is Thomas Lloyd. I'm a radiologist at the Princess Alexandra Hospital in Brisbane. So we are a tertiary level referral centre. We're a stroke centre, we're a transplant centre, we're a major trauma centre, and we're also the primary public facility for sarcoma in the state of Queensland. So I'm a radiologist with an interest in musculoskeletal imaging and specifically tumour imaging. I also am one of the lead musculoskeletal examiners for the Australian College of Radiology. So what we're talking about today is sarcoma and what the surgeon wants to know about sarcoma. Now, obviously, for the sake of a half hour or 45 minute, whatever this turns out to be, talk, I can't go over all of the fine details of everything to do with sarcoma imaging, but I do want to give a couple of important points, which I'll reiterate throughout the talk, things that I think can make your contribution to the diagnosis and the management of sarcoma more valuable. So, what I'm going to talk about is, firstly, is it a tumour? Secondly, where is the tumour? Thirdly, and this is to a lesser extent, what is the tumour? And then I've got a few particular peculiarities of certain tumours that can be important if you know the particular histologic subset of the tumour that you're dealing with. Now, the is it a tumour question is actually an important one because it's in many ways probably the most important contribution that you're going to make to the whole process, because once you've decided that something is definitely a tumour and it's a malignant tumour, then it's really not up to the radiologist to say what it is. That's a pathologist's job. You're involved in finding it, you're involved in characterising it, you're involved in potentially biopsying it, but the diagnosis comes from the pathologist. So we have a triage meeting that we run with their sarcoma surgeons every week at our hospital, where essentially we go through all of the cases that have been referred in that week. We go through the imaging, we go through the history, and in some ways it's for the purpose of, as I said, triaging, which case is the more important case, which case needs to be brought in quickly, which one can wait, that sort of thing. But also an important part of it is oftentimes we're sent things that turn out not to be tumours. Somebody's thought they might be, and because of that we can play an important role in diverting a patient from what would otherwise be potentially a fairly traumatic experience. Similarly, though, it's important to recognise when something is a tumour. And I've got a couple of examples that I'm going to show you of each side of that. So, on the subject of is it a tumour, I've got a case here. This is a 15-year-old boy who has presented with knee pain. So his general practitioner ordered an MRI scan, and just scrolling through it now, the most obvious thing is that he does not have an internal derangement of the knee. All of his anatomical structures in his knee are okay. What he does have is bone edema in the tibia. Now you can see on this image here, for example, there's a roughly horizontal line running through this area of high signal, and perhaps even a little bit more prominent on the non-fat saturated PD images. And so this case was interpreted as a stress fracture. Now there's a couple of points with this case that I think are important for MSK imaging in general, but tumour imaging specifically. All of this case was imaged with PD and PD fat saturated images. There was no T1 weighted image in the protocol. Now oftentimes T1s don't add a lot to the sequence, to the overall imaging, but and I think it's absolutely critical that there be at least one T1 weighted sequence somewhere in the MSK protocol, because what you can see on T1, which gets masked on PD, is when something is infiltrating the marrow fat. So when you see dark signal where there should be high signal fat, what that tells you is there's something there that shouldn't be there. Now, the clinical context will tell you whether that's infection versus tumour, but it does tell you there's something there that shouldn't be there. So that's mistake number one that happened in this case. Mistake number two is this was run as a knee protocol when obviously there's something that's going on that's not quite in the knee and it extends to the inferior edge of the scan. So what should happen is that either at the time or when you recall the patient, you scan back down to normal bone because there's something going on that goes to the edge of the scan, and we don't know how far it goes. And the third mistake, or the third issue with this case, is that there was no X-ray performed. The X-ray is absolutely fundamental, and so I'm going to show you that X-ray now. That X-ray was taken 2 months after this MRI scan when the patient had persistent pain. And so what we see on the X-ray, and I'll just magnify up on this for you, is there's an abnormality within the bone that's very poorly circumscribed. There's a fairly ill-defined area of mottling, some patchy sclerosis with some patchy lucency. It's got a very poor zone of transition, very difficult to see where the abnormality starts and stops. And then over here, you can see there's a lamellated periosteal reaction. So now that is there on the MRI, but it's a lot easier to see on the X-ray. And essentially what the X-ray tells you is that this is an aggressive bone lesion. So this turned out to be a Ewing sarcoma. And it was diagnosed sometime after that first MRI scan. Unfortunately, it was metastatic at that point. So I think it's important to consider the X-ray as part of your diagnostic process. People fall down into holes when they only do MRI. Now I'm going to show you another case which illustrates a similar point, but on the opposite side of the benign malignant spectrum. So this is a young man who presented with a painful lump in his arm. Now I'm scrolling through a T1 weighted scan here. I'm going to show you a coronal T2 fat saturated sequence and an axial T2 fat sat. There was avid contrast enhancement, which I don't have to show you, but there was avid enhancement. What we can see is there's a lesion in the soft tissues. There's extensive edema around it. The lesion itself is perhaps a little bit circular with multiple zonal layers, you might say. And there was some periosteal thickening adjacent to it. Now this was reported as quite likely to be a sarcoma, was sent into the sarcoma service, but again, no X-ray. So if we go and look at the X-ray, what we see is a very typical radiographic appearance of myositis ossificans. So what that is it's peripheral zonal calcification, which tapers away as you go into the center of the lesion. This is a benign process, a non-malignant process. It may well need follow-up. Occasionally they get excised because of symptomatic reasons, but this is not a malignancy. Again, it's very difficult to tell that on the MRI. So point number one out of all of this is you really need to do an X-ray. If you're not sure, do an X-ray. If something looks funny, do an X-ray. If you're thinking about a fracture, we'll obviously do an X-ray because the X-ray can tell you whether it's complete or incomplete. And quite often, the cases that we see that have run into trouble is because nobody did an X-ray. So, next point I want to make. Now, when I was a junior trainee, in my first year of training, I had a boss who used to talk to me about, he said, you should always be thinking about where is it before what is it. So you should always be able to put the lesion into an anatomical space, be specific with the anatomy of where something is, because oftentimes you'll find that the differential diagnosis is very different depending on where in the body something is. Is this a retroperitoneal lesion? Is it an intraperitoneal lesion, etc.? But also, if you're talking about what the surgeon wants to know, they want to know the anatomy. Because what they're thinking about is, can I get this out? What's the morbidity involved in getting it out? What other surgical specialties do I need with me to be able to get it out? And really the common language that we share with our surgical colleagues is anatomy. So if you're able to describe something in terms of its precise anatomy, they're much more likely to listen to you, they're much more likely to take you seriously, and you're much more likely to be making an important contribution to the patient. So I'm going to show you a couple of cases that illustrate this point. So this is a case of a myxofibrosarcoma of the chest wall that you would have absolutely no hope of diagnosing purely on the scan. All we could say is there's a tumour, it's heterogeneous, it's associated with a pleural effusion, which in fact turned out to be the most important part of the case because the enhancing tumour nodule in the pleural space was enough to make the surgeon back out and say, actually, I can't totally excise this lesion. But leaving that aside, what we can see is there's a lesion here, heterogeneously T2 hyperintense, that extends through the chest wall, and importantly, and you can see it just here, it contacts the axillary neurovascular bundle. So that becomes very important because that potentially changes something from being a chest wall excision to potentially a vascular reconstruction if the vessels are involved, to potentially a forequarter amputation if the nerves are involved. So being precise about where it is, what it's touching, becomes extremely important. Now, if we look at a different sequence on the same case, so what we've got here is tumour, which is involving the rib. It's growing both into and outside of the chest cavity. Part of it's enhancing, not all of it. But if we magnify up on this portion just here, what we can see is this is the axillary vein, which is deformed and indented by this tumour. So the tumour's here. Here's the axillary artery, which you can see is contacted over probably 180 degrees of its circumference. But importantly, and you can make them out here, this is the lateral, posterior, and medial cord of the infraclavicular brachial plexus, and they are not contacted by the tumour. So what that means is when you're explaining this to the surgeon, they're able to think, okay, well, I might need a vascular reconstruction, but I'm not going to be cutting the patient's nerves and therefore leaving them with either a flail arm or needing a forequarter amputation in order to treat this tumour. So be specific with the anatomy. Point it out. I often make key images on my PAC system where I actually draw arrows to things and say, this is what I'm talking about, and I'll point it out in the meetings as well. Another case. So this is a case of, it's a young patient with what turned out to be a B-core sarcoma. So this is one of the sort of small print tumours in the Ewing's sarcoma family. Now there's essentially nothing on the imaging that allows you to pick between these different subsets of the small round blue cell tumours. The more they learn about genetics, the more specific things get. We've got B-core subtypes, there's sick rearranged subtypes, there's Ewing's, there's PNET, there's unclassifiable small round blue cell tumours. You cannot pick the difference on the imaging. But what you can do is you can be specific with the anatomy. So there's a heterogeneous T2 hyperintense lesion that is within the bone. You can see there's definitely tumour within the cortex of the bone here. And when you compare this as normal marrow signal, there's tumour in the marrow as well. So, and actually, on that point, here's a T1 weighted scan to illustrate what I was talking about earlier. This is not normal marrow signal, as opposed to this, which is. So there's tumour in the marrow. But the tumour is also within the anterior compartment of the thigh, within the medial compartment of the thigh, and within the posterior compartment of the thigh. So that means it's violated all of the fascial boundaries, and it's gone into all of the compartments. So when you're talking about limb sarcoma surgery, generally speaking, the surgeons think in terms of compartmental anatomy, like this. So there are dense fibrous septae which exist to separate different compartments of muscles. Usually the muscles within a compartment have a similar blood supply and a similar nerve supply, but they also have these firm anatomical barriers which, to a greater or lesser extent, prevent things from moving from one compartment to another. So compartment syndrome is a fairly common, well-known condition where you've got hemorrhage or edema secondary to trauma that causes a rise in pressure within a compartment. And because of these fascial boundaries that stop the pressure from traversing the rest of the limb, you can end up with a critical ischemia within a compartment. So that's a bad thing. But if we're talking about tumour, often it's a good thing because those boundaries can stop tumour from extending from one compartment to another. It's important for us to know about in the context of anything that we might biopsy as well, because you don't want a needle, or a knife for that matter, but a needle to traverse compartments when you're trying to sample a tumour, because potentially that then seeds tumour into a different compartment, making any treatment, any surgical excision more complicated later down the track. Now this tumour obviously does not respect any of those compartments, and in fact the staging system for Ewing's and Ewing's families doesn't really, it's a different staging system for that subtype of tumour, but it's a nice case for illustrating fascia and tumour that's beyond the fascial boundaries. So what is a compartment? So Dr. Anneking, who is sort of the godfather of orthopedic sarcoma surgery out of Jacksonville, Florida. Obviously, he's not with us anymore, but he coined a staging system, which is still in use under the name of the Musculoskeletal Tumour Society staging system. It's not the same as the OJCC staging system, but it is a way of conceptualizing disease that a lot of the orthopedic surgeons will still use. So it's good to have your head around, and it's very much about compartments. But so he defines a compartment as an anatomical structure or a space that's bounded by natural barriers that prevent tumour extension. So cortical bone delineates a compartment. So you can have a tumour that's in a bone that hasn't gone beyond a bone, and that's a one compartment tumour. Fascia and the septae can limit extension of tumours, so that can keep something within a single compartment, as can cartilage, tendons, etc. Now, a lot of radiologists pay a lot of attention as to what is the tumour. And particularly you see this with registrars or trainees when they're trying to come up to the exam. They try to be very specific about what tumour something is. They give a lot of long differential diagnoses, etc. Most of the time you cannot tell. You can have an extremely experienced radiologist who knows a lot about tumour imaging, and they will just sit on the fence and say, here's a tumour, it's an aggressive tumour, I don't know what it is. There are some exceptions, and I've listed a few here, where the radiology is very important. So particularly with chondrosarcoma, more often than not, the pathologist will come and ask you what you think something is, because the radiology is critically important for chondrosarcs. Liposarcomas, people are very accurate at diagnosing because there's macroscopic fat in them. And then peripheral nerve sheath tumours and leiomyosarcomas are things that have specific anatomical relations which allow you to make the diagnosis. But most of the time you can't tell, and it doesn't matter because you're going to be biopsying these things anyway. with the exception sometimes of benign peripheral nerve sheath tumours, because you don't want to damage a nerve in the process of proving something is benign. So I'm going to show you a couple of examples of clear-cut cases and then a couple of examples of not so clear-cut cases. So axial T1 weighted imaging, if we follow the sciatic nerve as it becomes the peroneal nerve, you can see there's a lesion within the peroneal nerve. It's very T2 hyperintense. This is a peripheral nerve sheath tumour. One of the other things that you see with peripheral nerve sheath tumours, and this case shows it quite nicely, is you can see the nerve actually coming into it. I'll just magnify up on that for us. Here we go. You can see the nerve coming in at one end and then out at the other end. So that's very typical for a peripheral nerve sheath tumour. You could diagnose that with a high degree of confidence. In this case, we've actually got several peripheral nerve sheath tumours, this time in the posterior tibial nerve, but we can see here's the sciatic nerve. As we come down, you can see the nerve starting to branch into posterior tibial and common peroneal. There's a lesion within the confines of the nerve bundle. There's a second one, and there's a third one. If we put that onto a coronal plane, you can see 1, 2, 3 tumours all within the nerve. So that's a case where you can very confidently say this is peripheral nerve sheath tumour. This patient's got 3 of them, so they might have some sort of syndrome like schwannomatosis, which is sometimes called NF3. But this is a case where you can be quite confident with a diagnosis because you can identify the anatomy it's related to. The same is also sometimes true of another subtype of sarcoma. So this is a leiomyosarcoma, which is a tumour of blood vessels. So the occasional IVC sarcoma that you'll see is going to be a leiomyosarcoma. The vanishingly rare pulmonary artery sarcoma, which I think I've seen 2 of in my professional career, again, leiomyosarcoma. But what you're looking at is a vessel, and it's usually a vein, and the tumour arises from that vein. So if we follow this vessel on the scan, and again, I'll magnify up on it. So you can see there's a vessel, then there's a tumour, and then the vessel continues. You've got vessel on either side of this lesion. You can see it quite nicely in an orthogonal plane here. This tumour is intimately related to the vessel. This is a leiomyosarcoma. You can be really quite confident with that. You are still going to biopsy it, but you can be very confident with it. That doesn't mean you can always be confident with these tumours. This is a schwannoma, and I would not call this a schwannoma on the imaging. I would have absolutely no idea what this was. I'd be saying it's a large lesion that's hemorrhagic, it's greater than 5 centimetres, and it's superficial to fascia. Beyond that, I probably wouldn't be saying all that much about it. The contrast doesn't really help. All we know is it's a large lesion that's contrast enhancing and it's got hemorrhage within it. You can't call this a schwannoma with any degree of confidence, despite the fact that that's what it turned out to be. This case was a leiomyosarcoma. And again, you can't be confident with that. It's a large, predominantly fluid-filled, complex cystic lesion within the superficial tissues. It's got a lot of edema around it. It's got some areas of contrast enhancement. A lot of this stuff isn't really enhancement. It's just T1 hyperintense because it's blood. This was a leiomyosarcoma, and this is not one that you'd be confident in diagnosing just because it doesn't follow those rules. So oftentimes the actual histologic diagnosis is not actually that relevant unless it's got specific features that you can be confident about. There are, though, some important imaging findings that relate to particular tumours. And the way to often think about these is it's more of a, once you know what the diagnosis is, then you can go back to the imaging and interpret some things about the imaging that perhaps you wouldn't have interpreted beforehand. And oftentimes this is something that happens. You go back and forth in terms of the workup of a case. It'll be discussed at an MDT often before the biopsy. Then it gets biopsy, then it comes back to the MDT for a discussion. And so it's actually not that uncommon for you to know the histology and then to be asked, what else is there in this case that's relevant? So I've picked out 3 things that you sometimes see in the world of sarcoma that are important but are somewhat tumor specific. So fascial extension or fascial enhancement is something that you see with a couple of subtypes of tumor, and myxofibrosarcoma as well as superficial UPS or pleomorphic undifferentiated sarcoma are the 2 classics. Now what that refers to is, if you look at this case here, so this is a myxofibrosarcoma in the posterior compartment of the thigh, you can see there's a very T2 bright lesion here. But what I want to draw your attention to is at the margin of the tumour, you can see that there's this high signal intensity that continues along the fascia, the superficial fascia of the muscle. And you can see it again on the other side. On the post-contrast imaging, we can see that enhancement extends along the fascia as well. Now, you may see this in a whole bunch of tumours, but if you know the histologic subtype and you know that this tumour is a myxofibrosarcoma, that enhancement corresponds to tumour. The edema corresponds to tumour. It doesn't always with other subtypes. So if you are looking at a myxofibrosarcoma, you would put a lot more emphasis on the fascial extension. The surgeon would go a lot wider with their excision than they might otherwise do, because that edema and contrast enhancement out beyond the edge of the tumour histologically does correspond to tumour. So if you know that particular subtype, you make an emphasis on this, whereas perhaps you might not if you knew that it was something else. Now, lymph nodes are interesting when you talk about sarcoma, because by and large, sarcoma doesn't go to nodes. You'll see carcinoma of every body type, so colon, breast, etc., lung. It's common for tumour to go to nodes, and usually it goes to nodes first and then distant metastases. So that's the basis of the TNM staging. Usually there's the tumour, nodes, and then metastases. Sarcoma, that's actually quite rare. And most sarcomas, there's I think over 50 subtypes within the WHO textbook on sarcoma. Most of them don't go to lymph nodes, or if they do it very rarely, to the point that nodal extension in a sarcoma will automatically make it a stage 3 tumour, which is not what you tend to see with the carcinomas. There are some exceptions though, and I've listed a couple of histologic subtypes here. Epithelioid I've just highlighted because the case that I've got on the screen is an epithelioid sarcoma. It was heterogeneous, somewhat splat of a T2 hyperintense tumour with intense diffusion restriction and external iliac nodal disease. So each of these particular subtypes is known to go to lymph nodes more commonly than the remainder of the sarcoma subtypes, and I've got some percentages here that come from a paper that I've got listed at the bottom here. These are the cases that do typically go to nodes. Now there's a mnemonic, if you like, so you can think of care with C being clear cell, A being angiosarcoma, R being rhabdo, and E being epithelioid. These are the common ones that go to nodes. Now, there's an interesting lesion called an angiomatoid fibrous histiocytoma, which is a rare tumour. It's benign, but it's got this proclivity to go to nodes, or to cause enlarged nodes is a better way of putting it. So I'll show you a case in a second, but so one series that's been published, and again I've got the reference down here, had a series of 19 of these tumours. 7 of them had enlarged nodes at imaging. Only 1 of them was positive. So it's an interesting tumour where you often get big nodes, and sometimes very big nodes, that are actually not disease. They're somehow reactive to it. I've got a case to show you here. This is a angiomatoid fibrocystiosarcoma of bone, which is a little bit unusual. Usually they're soft tissue tumours. This one you can see it's involving the proximal humerus as well as the adjacent soft tissues. And as I scroll through it on this T2 weighted scan, you can see that it's a very dark tumour. It's got hemorrhage as part of it, and so this is hemosiderin. You can see there's a number of little similar looking tumour deposits in the posterior deltoid muscle adjacent to it. But the thing that I want to bring your attention to is the lymph nodes. When you look at the axilla, there's a number of very big, very irregular looking lymph nodes within the axilla. These were all PET avid, very PET avid actually, and they were benign. So we biopsied them. There was no disease within the node. When the lesion was excised and treated, all of the nodes went away. It's the sort of thing that ordinarily you'd look at nodes like that and you'd say, well, this patient's got malignant adenopathy or they've got lymphoma. And I mean, you do have to biopsy it to prove that you don't have that, but when you get your benign result back, then the question is, well, should we be taking out nodes in order to be sure? How many nodes, etc. So in fact, this patient does not need a node excision because of the particular subtype of tumour that they have. So sometimes knowledge of which tumour you're dealing with and what its particular imaging characteristics are can help quite a lot when you go back and revisit the imaging after you've got that diagnosis. Now, staging is often done with PET scan, and PET is very good, but it's not perfect. So I'm showing you a case here of a patient who had a melanoma. They had a PET scan for their melanoma and something lit up in their knee. So this is one of the cases from my institution. It's not the case that this particular case report is referring to. But so this patient had a melanoma hotspot in the knee. It's intra-articular within the knee. You can see it here. They've had an ACL graft, but they've got this thing at the back of the knee. This was a histologically proven tenosynovial giant cell tumour diffuse type, which is the correct pathologic term for PVNS. PVNS can be very hot on PET. I've seen several cases over the years where somebody has a PET to stage something else and something lights up in one of their joints. It's gotten to the point typically with us now where if you can do an MR and prove that it's an intra-articular lesion, particularly if it has the imaging characteristics that you tend to see with PVNS of low signal intensity, blooming on the gradient echo sequence, we don't need to biopsy them. Some people will still want to, and that's okay, but to be aware that PVNS or tenosynovial giant cell tumour can be very hot on PET. Now, there's another entity that's important to know about because of the opposite reason. So myxoid liposarcoma is actually a relatively common tumour in terms of sarcoma. I mean, there is no such thing as a common sarcoma, but myxoid lipo is relatively common within sarcomas. Now, it's a tumour that is extremely bright on T2 weighted imaging or STIR imaging on MRI, but it is not typically hot on PET. So a lot of papers have come out of recent years suggesting that the way these tumours should be staged is actually not with PET, but with whole body MR, similar to a multiple myeloma scan. Now, I've got a case that I want to show you. This is the first case that we saw in our institution where this really became obvious to us. We had just installed a PET MRI scanner, and we were in the process of quality assuring it, so we were doing PET CT scans on patients and then doing an MR, using the PET MR on the same patient to quality control, to attenuation correct, all that sort of stuff as we were getting used to the scanner. So this was a patient who had a mediastinal myxoid liposarcoma that had been excised with positive margins, and they did a PET scan to see what they were dealing with and could he be further treated. So going through the rotational PET pictures, you basically see nothing. This is all physiologic activity. Can't see any disease at all. So the implication would be this: there isn't significant disease. Now, the whole body MR was done on the same day as the FDG PET that you just saw. And if I magnify up on this, looking at this patient's skeleton, you can see they've actually got extensive bony disease, which goes the entire way through their skeleton. None of it lit up on the PET scan. See spinal disease and even disease within the surgical bed where he's just recently had his sternotomy for removal of his mediastinal disease. In previous times, he would have had a PET scan and incorrectly believed that there was no systemic disease, which would then have presented clinically later on. And we've seen cases where somebody's presented with disease that's extremely difficult to see on CT, on PET, and then it's extensive on MRI. So, myxoid liposarcomas, if you need to stage a myxoid lipo, you're better off doing it with a whole body PET scan. Sorry, what am I saying? A whole body MR rather than PET, because PET tends to undercore the disease. What we tend to do is we'll just do coronal stir sequences. They're fairly low resolution. They're quite dirty pictures, but because the tumour is very bright and it tends to go to bone, this particular tumour, because the disease is very bright, you can see it even on a low resolution fluid sensitive sequence. You then might do extra sequences to characterize the stuff that you've seen. So think of it more like a screening test, similar to a myeloma study. You don't need high resolution to pick the disease. So what we've talked about, and the things that I wanted to emphasize for this, is there are a number of subtype of pathologies that can mimic tumour that are worthwhile being aware of. Things like myositis ossificans, things like Morel-Lavallee lesions, post-traumatic lesions, etc. Knowledge of those entities will often help your sarcoma surgeon enormously, because they take the patient off the sarcoma pathway and send them down a different management stream. Don't ever neglect plain film, because oftentimes the diagnosis is on the X-ray, not on the MRI scan. Think about where something is before what it is, and the more specific you can be with the anatomy, the more people will listen to you and pay attention to what you have to say, because the more help you are to the surgeon by spelling out what they need to know in the language that they understand, which is anatomy. And then, for interest's sake, I've shown you a number of cases of interesting things related to specific kinds of tumours, like the fascial extension that you see with myxofibrosarcoma, the fact that most sarcomas do not go to lymph nodes, but there are some specific ones that do, and you can remember them using CARE. Angiomatoid fibrocystic sarcoma is a